So, I'm going to talk to you today about trying to improve the diagnosis and early referral of patients with AxiaL SpA. And oddly, that turns into ideal. So, delay in AXSpA diagnosis. I don't need to tell you that low back pain is incredibly common. Or, it's a big chunk of what GPs have to deal with. Prevalence of 15% in Western Europe, and top of the conditions causing disability. In terms of diagnosing AXSpA, it's really common to have back pain, and a proportion of those do have AXSpA. But trying to tease out which of them have AXSpA and which of them have biomechanical back pain is really quite tricky. If you look at the mean duration of delay between symptom onset and diagnosis, it's between 4 and 9 years. If you look at the median, then it's between 2 and 5, so it's a little bit less, but that does mean you've got some patients that are out at 30 years that are skewing the mean up towards that 4 to 9 that's often talked about. And there is a question about why that delay is there. Some of it's because lots of people in the general population just don't know AXSpA exists. They've got, I've got back pain, I'll just put up with it. There is a difficulty with GPs and GP clinicians recognising inflammatory from non-inflammatory back pain. There's also a problem with physios and orthopods and back pain services recognising it. And actually, it's not that easy to diagnose either. So there's a fair chunk of patients that come to rheumatology and they're patted on the head and sent away saying, no, you're fine. And they're not. They've got it. We just can't prove it. The barriers to diagnosis are not thoroughly explored and are poorly understood. So lots of the focus on getting over the getting to that diagnosis, reducing that delay, has been focused on GPs. To a degree, that's not unreasonable, but we don't really know how much those other factors impact. So we don't have lots of data on how long do patients sit at home with their back pain, not seeing their GP. How many have seen the physios and they've just been ignored. So there is a slight sort of over-exaggeration maybe that this is purely a GP referral problem. Having said that, my £2.5 million study is looking at the GP referral stuff, but it's not the whole story. Lots of low back pain, 10% of those carry on for at least 3 months. Obviously, we look at red and yellow flags to make sure how severe they are and all that sort of stuff. There are quite a lot of standard back pain guidelines. There's a start back tool which lots of people use. Now, the one thing about the start back tool, which is great, and I work intermittently at Keele, so I'm very supportive of it. It does work. But if you look at the very beginning of it, it says first exclude all other nasty diseases, including inflammatory. So none of that evaluation and none of that cohort they've designed it on actually included any AXSpA patients at all. So there's you rule them out before you go into that start back tool. And if we look at how well GPs recognise AXSpA, and clearly not this room, that goes without saying, between 13 and 90% of inflammatory back pain symptoms aren't recognised as inflammatory back pain symptoms by GPs. So that differentiation between mechanical and inflammatory, actually being able to describe AXSpA, quite a lot of GPs can't do that. And there's also this ongoing perception that AXSpA is a male-dominated disease. When I was at medical school, I was taught it was all blokes, 90% male, 10% female. All of the more recent studies, particularly with the change in the classification where we're using MRIs, show that it's actually a 50-50 disease. Women don't get the X-ray changes. So when we were using the modified New York criteria for ankylosing spondylitis, they just weren't recognised. But it doesn't mean they don't have the inflammatory disease. And the efforts that we've made so far to try and reduce this delay, they've not been great. We've got the ACES classification criteria, so, how do we, identify those patients with information? How do we incorporate MRI studies in, examinations in? And there's also the AxiaL clinical guidelines that NICE did in 2017, and neither of those introductions have actually reduced the delay to diagnosis. There are a couple of small pockets where people have said, oh, we're really good, we've reduced it to 1 year. Do I truly believe them? Maybe not. There is a study that's ongoing, which is an inception cohort for new diagnosis AXPAR, called BASICS. It's been adopted by the British Society for Spondyloarthritis. Helena, up in Leeds, is the chief investigator. There are already 20 plus secondary care centres recruiting to this. And as part of it, I chucked in a questionnaire at the very beginning of it, just as a one-off, which looks at the barriers to diagnosis. So that looks at how long is it between onset of symptoms to seeing a GP. Once you've seen the GP, how long is it before you get referred on? If you see a physio, how long is it before you get referred on? With some literally tick box options of why was that delay there? Why didn't you go and see your GP? Was it because you didn't know about AXPAR? Did you just think it was okay to put up with it? Did you not get on with your GP and hate them? Lots of things. So that may well give us some idea about where these pinch points in diagnosis are, and look much wider than just, is it GP referral? In terms of the spondyloarthritis pathway, this is what NICE in 2017 said. We've got 3 of the people that suggested this. So for low back pain, starting before the age of 45, lasting over 3 months, you look at these, 9 different features. And if you have 4 of those, then you should refer for rheumatology assessment. If you have 3 of them, you check the B27 and refer for rheumatology assessment. I do not believe I have ever seen a patient referred under these guidelines. They are clunky, they are big, they are cumbersome. They don't really work well. I mean, they work okay, but they're just difficult to use. And we knew that when we put them into the guideline. It's just that it was the only evidence base that existed that was robust. But this guideline specifically said, in terms of what research to do next, we know these referral guidelines are a bit rubbish, we need to redesign them. Now, the Braun pathway, which is the NICE pathway, has been superseded from a clinical academic perspective by a new study by Baraliakos from the same research team. And that says if you've got low back pain starting before 45, more than 3 months, then if you measure early morning stiffness for 30 minutes, improvement with NSAIDs or raised CRP, if you have one of those features, do a P27 and refer if it's positive. If you have 2 or 3, refer anyway. This is much simpler. I like this. It kind of works. There's always a but, isn't there? The study was hugely underpowered. It was 400 patients, it was big, but they actually published 30 different ways of trying to determine axial spondyloarthritis. And for those that know stats, the Bonferroni correction on this means that none of the p-values actually counted. It's not been independently validated. It's not a one-stop shop. So if you look at these, you've got to prescribe your patients NSAIDs and you've got to take a blood test. So you can't see them and say, all right, I'm seeing you with your back pain, off you go to the rheumatologist, there's stuff to do. And it's also that the cohort that they had, it's mostly a German cohort, and 70% of the referrals into the study were not from GP practice, they were from these slightly hybrid trauma centres, so full of orthopaedic surgeons. So it's difficult to actually equate this to the UK. In terms of performance, we look at the bottom two, the nice one and the Baraliakos. Sensitivity, I mean, Baraliakos, they picked the best of the 30. They kind of cheated a little bit, but it picks up 9 out of 10 patients with AXPAR, and for every 3 patients referred, 2 of them have AXPAR. So potentially it's got really good features, much better than NICE, where it's sort of it only picks up 2/3 of them. But it's not robust data yet, and it's why it's not being used. So, in terms of ideal, we've got the NICE criteria, we've got the all-party parliamentary group from the Houses of Parliament that had a review of the delay in diagnosis to AXPAR. They've got NAS who are jumping up and down and banging the drum quite appropriately. And all of that is saying, how do we get these referrals better? And so myself and some very lovely, clever people, I'm not including myself in that, by the way, put together a program grant and said, let's actually try and find out. And so we're looking at existing AS cohorts. We're doing a big cohort collection and looking at 720 patients very carefully. There's then an even bigger national study looking at implementing what we find the pathway. And then there's an oversight bit of process evaluation of whether we're measuring what we think we're measuring. And you can see lots and lots of august academic centres involved in that. So I'll take you through these bit by bit. So in terms of the AXPAR cohorts that we've got actually got some quite big cohorts. We've got the British Society of Rheumatology AS cohort, which is about 2,000. We've got the Scottish and Irish cohort, which is about 2,500. There's the EasyQual study, which is one of my old studies, which is about 600 or 700. And overall, that gives us 5,000 patients with AXPAR that are really well described in terms of how long their delay to diagnosis was and what their clinical features are. Doing some POSH stats, which is individual participant data meta-analysis, that should allow us to work out which in the UK, what variables predict that delay to diagnosis. And we've already got lots of variables from the European studies, things like buttock pain and early morning stiffness in response to NSAIDs and all the things I've already been talking about. This is making sure that we're not missing anything which is UK specific and also GP specific as well. But we'll look at those variables and make sure they are modelled in part 2. So, part 2. We're looking at collecting, well, a minimum of 720 patients. We need 720 patients with full data. So we're allowed to collect up to 900 patients if people fall out and don't give us all their data points. And we're looking for patients over 50. Now, we've set it at 50 because although the classification criteria are 45, if we've got a delay of diagnosis of 2 to 5 years, we need to be seeing them until they're 50 to pick up that delay. The onset does have to be below 45 for them to be eligible, and they have to have back pain for more than 3 months. Currently, they have to have back pain currently, but also back pain for at least 3 months in the last year. Because when we talked to our PPI groups, they were saying, well, sometimes when I see the GP, I've had lots of back pain that year, and I've just got it again, but I've had loads that year. And so we're trying to build in that idea of that recurrence of back pain. Sometimes if you see a patient and they go, well, I've got it back for the last week, they still need investigating and thinking about. If that makes sense. Okay, so the way that we're going to set this up, we're going to have 5 to 8 specialist centres around the country, GP practices, nice smiley, happy face, like all GPs. And they can be big or small, and they will feed patients into those specialist centres for assessment. At the moment, in the red, we've got the ones which are going to be recruiting, which are Leeds, Liverpool, Stoke-on-Trent, Norwich and Bath. And if we have any slip in our recruitment, we've got Newcastle and Coventry in our back pocket. And we have the great and the good helping run each of those centres. So we've got Helena up in Leeds, the wonderful Nikki in Liverpool. I'm not sure who the guy in the middle is. And Edwin and Raj in Norwich and Bath. And the idea is that the patient attends their GP or their GP clinician. So this can be your extended scope physio, your practice nurse, anybody that's in your practice seeing the back pain patients. They're identified by the receptionist or the GP or the GPC, and also from a pop-up on SNOMED saying, this patient might be eligible for this study. Do have a think about it. There's a very brief eligibility check for the GP within the consultation. Basically, have they had onset before the age of 45, making sure they don't already have an inflammatory condition diagnosed, no suspected red flags, and suitable for research. So basically the stuff that you'd be doing in a back pain consultation anyway. And if the GP thinks that's a patient that would benefit, then they can suggest the study to the patient, and the patient just consents to be contacted. They don't have to do any major consent. The plus of this is that when you're seeing patients in your clinic, what you're offering them is a full investigation, which is what all patients want and none of them get. I'm not saying that's inappropriate that none of them get it, but... So we think it should be relatively easy to recruit. If the patient says, yeah, I'm interested, they receive a text to decline or accept contact from the ideal study groups. They get a link to a website which includes a patient information sheet, and we're also developing study videos in English so that we can get people that don't have high literacy levels, and in the 4 top alternative languages for patients that have poor English, and those are Polish, Romanian, Urdu, and Punjabi at the moment. The Romanians have recently come up the lists. If the patient's interested, they send back a telephone contact number. They get a phone call from the secondary care site, from the research nurse there, and they double-check their eligibility, making sure that they did have the onset before 45, no inflammatory stuff, no red flags, including sciatica. Also, no contraindications to MRI. So if the patient's pregnant or they've got a pacemaker or they're very claustrophobic, again, we need that data to get our final endpoint, so those patients would be removed as well. And they do an online consent, and then they're booked to a new patient clinic, and they go onto the website and they fill in a 30-minute prom. Right. So, in terms of diagnosing them or not, we see all these patients as new patients. They're seen in the 5 centres, and our estimate from the other cohorts is that 14% of this group, the under 50s with chronic back pain that don't have red flags, 14% will end up having AXPA. So they attend the new patient research clinic, they have a full assessment with a rheumatology specialist that knows what they're talking about, one hopes. They do their prom completion if they've not done it before they come. They get bloods for CRP and HLA-B27. They get an X-ray of their pelvis and sacroiliac joints. Full history is taken, further consent for biomarkers if they wish to, and they're booked for an MRI scan. If they have the MRI, those are locally checked for red flags, so the local team will look for infection, cancer, that sort of thing. And assuming that that isn't there, then it goes to a central group in UCL that double read it and feed back to the local PI, who can then look at the history, the clinical features, the patient-reported measures, B27, CRP, X-rays, MRI, and give an idea about whether the patient has AXPA or not, and they give a certainty score. And they say, yes, they've got it. I can't diagnose it, but maybe. I can't diagnose it, and probably not, and no, they definitely haven't got it. The patient is then sent a letter with their diagnosis, whether they have AXPA or not, and if they've got AXPA, they get some AXPA information and are booked back into rheumatology clinic. If they haven't, they're sent stuff on biomechanical stuff and how to help self-manage. And the GP has sent a letter with all of the investigations and all, so they've got good insight as to what happens.
So they get the X-ray and the MRI?
Yes. Yes, and we at the moment, NICE guideline actually says that you should do the X-ray before you do the MRI, and that's a cost-saving thing in that X-rays are relatively cheap. And so if you do an X-ray and you see the sacral hiatus, you don't have to spend the MRI, order the MRI and have that additional cost. That is contentious, I think, is a reasonable way to put it. An additional benefit of this study is we'll be able to see if it makes any difference at all, because we don't have that data. Okay, modelling. So once we've got all this stuff, once we've got our 100, 150 patients with AxiaL and our 600 without, we can then look at all their variables at the beginning, their buttock pain, their response to NSAIDs, their CRP, and go, well, what things at the beginning would predict whether you're in that group of 100, 150 or not? And that's and if we can identify those things, we can then say, well, if you just measure them, you can predict which ones need to come and see rheumatology. So, stats modelling. All these predictive variables go into a basket and you pick out the best ones. And then what we're doing is we're involving patient partners and community of practice. So it's, the researchers are doing this, but then we're putting it to patient partners and a community of practice to look at those variables and see if they make sense. Now, I didn't know what community of practice was before I started doing this, so I'll explain what it is. It's a group of people that are interested in the disease that we're thinking about and the outcomes we're thinking about. So it's not just patients, it's GPs, it's rheumatologists, it's patient groups, it's commissioners, and it's hospital managers. It's the people that look after the whole thing. It's a holistic view. And you know, it's really important. If this study shows something that's incredibly expensive, none of these people will care apart from the commissioner, but they're going to go, not on the Ornelli, are you going to be able to use that? And so it's trying to get that overview, or that holistic overview of what we're suggesting. So we get the review, and these groups, they actually have to think. It's not, it's proper patient partner involvement. And they have to look and go, is that something when I see the GP and they ask me those, is that something that's easy to do? Is it troublesome? Is it a one-stop shop? Is it doing a CRP and having to come back? Or is it just asking me, well, I've got buttock pain, because that would be so much easier? And it's trying to get an idea between realism and idealism, the ideal thing the absolute best, and actually what's reality, and also the cost of these things. If the study says, let's just MRI everybody because that's easy, that's not affordable for the NHS. And in terms of this split between realism and idealism, CRP and B27, of course, that's a repeat visit, a review of those test results, and the patient has to have phlebotomy. And in terms of NSAID response, again, you have to contact the patient and say, how did you respond? Did it work? Possible side effects, some patients will be intolerant and contraindicated and can't have those things, if they've got colitis or something like that. And once we have the model and this going round and round with the PPI and community of practice group, they get to okay, this is actually what we think is best. This is going to be the most pragmatic way of doing it. It might not be the exact best statistically, but it's the one that can be implemented. We then compare that to the Baroliakos, which is the best that's out there. And we can use all this data to validate the Baroliakos or not as well. We then have a best referral pathway. And we put that into a GP pop-up. I know you all love pop-ups, I'm sorry. I do apologise, but it really is the only pragmatic way. The great thing about a pop-up is that it doesn't look at the patient, it just does its thing. So all this stuff about, well, women don't have AxiaL doesn't matter at all, because the pop-up won't say, is this a man or a woman? It'll just go, here's somebody, think about it. So it gets rid of some of those biases that we all have. Pop-up activates in patients under 50 with 3 months of back pain. We're hoping for 3 or 4 simple screening questions and on-screen advice as to whether to refer to rheumatology or not. If, as we hope, this is going to be simple, highly sensitive, highly specific, there's also the question of, if we put it into practice, will the GP and the patients actually use it? Will they play nicely? Which is why we have a phase 3 and implementation arm. And what we're going to do is we're going to cluster randomise GP practices across the UK, nothing to do with these specialist centres anymore. And they'll either have the pathway in place or standard practice. And we'll do some qualitative research just to explore the barriers to implementation of this. But essentially, it's just watching what happens under the IT system. It's, do you click through? Do you refer to rheumatology? And under SNOMED, a year later, have they been diagnosed as AXPA or not? So the data collection is all electronic stuff which is already collected, which is why we can do 9,000 patients. You don't have to consent individual patients. It's per GP practice, because it's very, very light touch. And 1 to 4 weeks after their appointment, then the patients will get a text invitation saying, we're doing this back pain research, we know you've recently seen your GP with back pain, would you like to play? So not saying anything about AXPA at all. And that will give us some outcome prom data on this cohort as well. And hopefully we can then prove that not only does it work, but also people use it. And that's what NICE will want for us to implement this. Unbelievably, that's going to take 6 years. We've got a brilliant cohort. We've got 700 or 800 patients probably, with x-rays, MRIs, specialist review, blood tests. And there are lots of bolt-on things which we're also planning. So radiologically, there are plenty of studies which look at patients with AXPA and say, this is what your MRI shows. And the artificial intelligence can read all those MRIs and go, right, this is what we show. They can sometimes do it against general population, but they can't do it against under 50s with back pain that present to their GPs. They can't actually do it against the patient group that is important. And this data will allow us to do that, so they can actually tease out, because it may well be that patients with non-inflammatory back pain do have quite a lot of MRI changes to their facet joints and their sacroiliacs. We don't really know that. If we can teach the AI this, that may well help the perennial problem of almost all radiologists are rubbish at reading AXPA MRIs, because they are. And Tim, who's based at UCL, has got a £1 million fellowship submission just going in to help him do work on that. And we've got our fingers crossed, but I think it's not a bad submission. We've got very similar things with biomarkers, because we've got this non-inflammatory group. It's not just the general population, it's this group that don't have AXPA. And so looking at biomarkers, looking at genetics, it's actually much stronger because your comparator group is the group you're actually interested in when you're screening. And there's this thing called a polygenic risk score. Again, I didn't know what that meant 6 months ago. But basically, it's an algorithm which looks at all the genes and can earmark which of those and ascribe a different weighting to each one, puts you at risk of having AXPA or not. So it's a bit like your B27, but souped up with all the other genes around it. And again, bright young thing in Manchester, putting in a fellowship as well, with the help of Journalists England and Manchester. We've got an additional PhD funded through the NHR Primary Care School at Keele, looking at, we've got that 5,000 patients that we're looking at for the variables, but actually can tell us quite a lot about outcome and whether that delay to diagnosis changes patients' outcome. So we don't actually know that very well. And also that PhD student will almost certainly be looking at the current screening tools. So the NICE screening tool, the things on the NAS website, the SPADE and things like that. They can look at that and actually validate them in a patient group that is from GPs, because all of those are being validated in a secondary care cohort, which again is the wrong cohort because it's not what you're using it for. We even have a PhD in Salford University looking at EDI, so underserved groups, equality and diversity issues. How do you get these patients into research? And we are also looking at, I was talking about this certainty, this, yes, they've got it, that we can't say they've got it, but they might have it. I'm really interested in that, because we can't diagnose it right now, but it feels like it probably is, but we can't say, yes, you have. That's a really common group of patients for us to see. And the study so far is designed as a cross-sectional, we see them, we say yes, no, they go. What we're interested in is, why don't we follow that lot up? We can get them to, we've already got a website where they're filling in proms and things. We can do that at year 1, 2 and 3. We can look at maybe MRIing them at year 1 and 3 if they're in that maybe group, and see how many more we would pick up, what changes over time. We haven't got the funding for that yet, but you're allowed to do posh funding things when you've got a programme grant, and we're putting it in for that. But I'm optimistic that we may well get that funded, because I think it's a really interesting, because we don't have an answer for, if you say a patient in rheumatology and say, no, you haven't got AxiaL SpA, we can't prove it, we haven't got an answer for what do you do next. Nobody knows. I've been talking for England, I'm sorry. Any questions?
That was amazing, thank you. Thank you, John. It's fantastic to hear that this is being looked into, because there are such delays. So, questions, please, for John. And Siobhan's got the microphone.
Thanks very much, John. Just a really quick question. Under 50s, is there a lower end to that? Is it over 16s or?
Yeah, we're doing 16 and up. It's tricky, but below 16 they officially fall into enthesitis-related JIA, so because you've got different classification criteria, it's hard to include that group.
Thank you.
Hiya, I'm an advanced practice physio up in Scotland in primary care. Just a question about the X-ray. I never send anyone for X-ray. I do the bloods plus minus the referral, if depending on my level of suspicion. Because I always thought you can't rely on X-rays, because that's why obviously they thought it was a male-dominated condition because women don't show up. But should I be?
Nice to say you should.
Okay.
We've got some of the great and the good on the research group, and we are totally split down the middle. So it is not, although it is nice to say you should, it is not standard practice to do that in all centres by any stretch of the imagination. And indeed there are some centres like Oxford that actively ban it, and you can't order it. Which is fine, but we don't know the answer properly.
If I remember back to our discussions when we were all sitting on that committee in NICE, it was very cost-driven. It was very, if you could make a diagnosis based on an X-ray, you didn't need to have an MRI. But I would agree with John, the MRI adds so much more information and helps manage the patient. So,
I mean, when you're sitting in a rheumatology clinic, the other thing is timeliness, because I personally report all my X-rays and MRIs. So if I've got a patient I'm seeing, and I think, okay, you've probably got AxiaL SpA, if I send them to X-ray and they come back half an hour later, I can make the diagnosis there and then. I don't have to wait for an MRI and see the results. And so some of it is just flow through, patient flow as well.
Sorry, multiple levels to my question. Would it maybe depend on the chronicity? Because I know it can take several years to show up an X-ray if it's gone in. So maybe would you suggest maybe perhaps if the person's male and they've had these issues for a few years, perhaps think about it a bit more, because that could save a bit of money, rather than female who's just had the issues for about a year or so.
Yeah, I think that's a very pragmatic and sensible approach. And the other bit in the guidelines is if you've got somebody under 18, there's no point doing an X-ray. Because the growing sacroiliac joint, and is still growing at that stage, is so unreliable to look at. For that group, you go straight to MRI.
Okay. And would that be primary care decision, or would it be maybe rheumatology decision about the X-rays and MRIs? Because I'm very aware that, primary care are not experts in anything. That's the point. But
I think it. At the moment, my understanding is that most of the commissioners say that's ordered by secondary care. Although there are some places around the country where that's not the case. So it does vary, but it's very much based on the ICB's opinion and the commissioning opinion at this stage. Hopefully we can influence that with a bit of evidence base, but it will take time.
I was just going to add that we can't get SI joint X-rays
because the requests are triaged by a radiographer now who just says no, 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 no x-rays for back or pelvis. If you put query OA hips, you'll get a pelvic x-ray. But it's just not great, really.
Maybe send them the
nice I know.
guidance.
Yes, yeah. Yes. Thank you.
Hi there. Carl Buick. I work in the medical affairs team at Novartis. Just a quick question. You mentioned really early on at the beginning of your presentation about the often women don't have the X-ray changes.
Yeah.
I'm also aware that sometimes women or people that have non-radiographic disease can present slightly differently in terms of where they feel the pain, where they feel the symptoms. And I'm just wondering in what your perception is of how much of a challenge those first of all, how atypical are those presentations, and secondly, what kind of a challenge do those atypical presentations pose in primary care in terms of identifying those patients, given that we already know that it's difficult to identify anyway?
I mean, certainly women present later, so they get onset of disease, symptomatic disease, a small number of years later than men. With a slightly increased diagnostic delay as well, they're actually diagnosed that bit later. There's not enormous amounts of atypical. They're not that atypical. There's not a lot of data which shows huge differences in BASDI or range of movement or anything like that. Probably they have got lower CRPs. Related to the fact they have non-radiographic AXPAR, in general, you get a lower CRP, or fewer of them have a CRP response. So that's an absolute definite. But the rest of it is all a bit grey, I think.
So, just coming back to X-rays and MRIs, I agree the MRI gives you a lot more information, but it gives you too much information, mostly. And I agree that most musculoskeletal radiologists, or even radiologists, have trouble interpreting what they see. And we know that people with non-AXPAR can have abnormalities of the SI joints. That's become clear over the last few years. And if you're ordering an MRI and you don't see the MRI, but just the report, I think it can be very misleading. So I think we've got to be careful about that. The other question I had is about your coding in your study, because we found in Leeds recently that the change from the diagnosis of AS to AXPAR and the coding therein caused a lot of problems in identifying or following through diagnosis of AXPAR in primary care. I just wondered how you'd handle that, or were thinking of handling that.
Yeah, I mean, Keir had done some work on the CPRD identification of ankylosing spondylitis, but that also includes sacroiliitis and other of the codes that you can include. So it's not been redone for AXPAR, you're absolutely right, but the hope is because there are non-ankylosing spondylitis descriptors there, that if people aren't going, well, I'm not sure what that disease is, they'll put in something like sacroiliitis. And talking to the guys, the hope, it was the hope rather than the no, but it seemed like a reasonable approach.
Hi, my name's Caroline. We work for a primary care service, and we are the advanced practitioners for physio, and we actually are the first people who come in contact with all MSK conditions. So our clinical lead is a consultant rheumatologist as well. So the pathway we've got at the moment is patients under the age of 45. We do the whole spine MRI, including SI joint, and the blood screening as well. Would you say that it's only over 45s that would need the X-ray? Because we can arrange SIJ and pelvis as well, you see. And we have an MDT every week. We speak with our clinical rheumatologist. So what the question was, when they have the scan, how often do you often see changes for the chronicity of patients who might not have like the active lesions?
Yeah.
How often does it develop within that? You've got a high suspicion that it is that.
So the first thing to say is MRI scans are rubbish. If they're positive and they show clear inflammation in the right way with structural change like an erosion or sclerosis, they're relatively reliable. There's been a new development in the last 5 years around patients that have recently given birth or are heavy physical activity, sportsmen or jobs, where we know that if people put their sacroiliac joints under a lot of strain for those reasons, they get bone marrow edema. So there was a study looking, I think it was the Dutch hockey team, female hockey team, and they were MRI'd, and it was something horrendous, like 40% of them could be diagnosed as AxiaL on the MRI after a match. It was, you know, substantial. And clearly none of them did have it. For that reason, the advice has changed a bit in that when you look at an MRI, you not only look at the bone marrow edema now, you do look at whether there are erosions or sclerosis and things like that. And there's an extra weighting for patients that have that. There are a substantial number of patients that have AxiaL, have an MRI, and the MRI is negative. There is, under the classification criteria, and health warming, it's a classification criteria, not a diagnostic criteria, but it's often used for diagnosis. There is obviously the clinical arm of diagnosing AxiaL that you can use under the ASAS criteria, which is if you're B27, if you've got that 3 months of back pain and all that sort of stuff, and you're B27, and you have, I think it's 2 of the indicators in the grey box, which are things like family history of psoriasis, uveitis, psoriasis, colitis, high CRP. If you have those, you can still make a diagnosis under and say yes, you've got AxiaL under the clinical criteria, and that under the original ASAS paper, that picked up about another 20-25% of patients allowing that. So you can do it that way. The only snag is, unless you've got proof of inflammation, it's a bit iffy to do anything other than treat them with NSAIDs. They don't really fit the NICE criteria for treatment. But you can diagnose them at least.
Thank you.
Thank you very much. My question is the AxiaL screening for AxiaL spondylosis. Is it like a one-time thing, or how do you determine, like, after how many months or years you screen again? Or
yeah, it's really hard. It's not a one-time thing, because like everything that's inflammatory, things wax and wane, and as I've just said, MRIs are rubbish. So it's so common. And actually, rheumatologists generally are a bit rubbish as well. I have to retrain so many of our juniors coming in saying, then they go, oh, the MRI is normal, therefore they can't have it. And they gradually get beaten around the head until they understand that's not the case. Just means you can't diagnose it yet. And so this idea of certainty of diagnosis is actually quite a useful concept. There's a little bit of data about it from one of the European cohorts, the space cohort, which is giving us some glimmers of insight into that. But it's absolutely the case that if you've got somebody that feels like they're AxiaL, if their investigations are negative, it doesn't mean you rule it out. It means you just have to keep it under review. I will, the ones I am absolutely convinced have, I'll actually bring back to follow up maybe a year's time and see what they're doing. And if things are worse and flaring, I'll re-investigate them at that stage. I've had one patient that I was absolutely convinced had it. And I MRI'd them, and I think she had 5 MRIs. All negative, and I thought, okay, well, it was postpartum onset, and of course, anything inflammatory can come on postpartum, but equally, if it's postpartum, you can get loosening of the ligaments and things like that, and it was always on one side. And I thought, okay, I give up. I can't prove she is. I'm going to send her, and she was really bad, I'm going to send her for surgery on the sacroiliac joint to fuse it. So I sent her to the surgeons, they agreed, they did an MRI just as a planning thing, and she had beautiful inflammation. And that was 6 years on from when I first saw her. So you just have to have that level of, am I sure? And not trust the results completely.
Can I also ask, in your the study, the steps you mentioned, Because I think your third step was that somebody will call the patient and they will screen them for if they can have MRI and bloods and all that. Why don't you put on the step 2 where it saves the time for the step 3 person?
Mostly because the GPs on our research panel were very certain that we needed to minimise the GP workload to get patients in, is the easy answer. So we wanted to make it as attractive and simple as we possibly could.
Thank you.
Sorry, just a practical question really. So I work in a MSK interface clinic with AHPs, physio AHPs. Testing for HLA in patients who present late. Obviously, we, as you said, we see a huge cohort of patients who present with chronic low back pain. And historically, they've often not had HLA testing. So I'm thinking about those patients that come in maybe late 50s, 60s, even 70s.
Yeah.
And they would fulfill the criteria for having an HLA-B27 under the NICE guidelines. They've got 3 criteria, potentially more. What are your thoughts on HLA testing, HLA-B27 testing in the older age groups?
I mean, it's certainly worth investigating how long they've had the pain. It is relatively robust that the vast majority of patients do get some inflammatory pain before 45. But if they're 70 and they've had it for 25 years, I would absolutely count them in that group. B27 is tricky. It's got a use, but it's 9% of the UK population, and 0.5% of the population have AXPAR. So only 1 in 18 people that are B27 positive have AXPAR. So you can't use it and say, right, I've done the test, that patient's got AXPAR. But you have to build in the other clinical bits to it as well. So it's not as concrete as we think. There is a hope that this polygenic risk score stuff that I've said might give us more, something a little bit more robust. Whether that's going to be available on the NHS or if that's going to be a commercial thing, we don't know yet. But it's got use, but it's not something to hang your hat on.
Oh, well, 2 more.
Hi, just thinking about re-referral to rheumatology if you've still got a clinical suspicion, because I've been positive someone's had it and they've had a scan and it's come back negative and they've been discharged. And I thought, well, okay, well, I thought an MRI was gold standard because that's what we're told, an MSK MRI is gold standard. So the fact that you said it was rubbish is quite enlightening to me. So basically, what would you suggest the time frame would be for a re-referral to rheumatology if you still have clinical suspicion? Because obviously we give words and advice to the patients if your symptoms change. And I always say you can't close the door on a diagnosis.
Absolutely, yeah.
But rheumatology aren't going to like me very much if I keep sending the person. That's the time frame wise. You mentioned a year you'd get someone back. Is that what you'd suggest?
I think a year is reasonable. And I personally don't tend to reinvestigate unless their symptoms are worse than last time they had a scan.
Right, so it's that worsening factor. So roughly about a year, but the symptoms have to be worse, not the same. Yeah, okay.
Yeah, because otherwise it's, somebody with chronic back pain that's grumbling along, that's non-inflammatory, they're going to have exacerbations, but it's going to be roughly the same level. And inflammatory stuff, you do tend to get, I mean, not everybody, but you do tend to get decent flares occasionally and think, okay, that's the time to investigate.
And would you do the bloods again then, or just do the re-referral?
Bloods are tricky too. So you rely on CRP, but we know that you can have patients with rip-roaring inflammation and their CRP is completely normal, just like you do with psoriatic arthritis. So between plus or minus 10%, 50% of patients with AXPAR and psoriatic arthritis don't mount a CRP inflammatory response. So for those that do, it's great, you can tell. For those that don't, it's a real way of confusing people and going, well, your CRP is fine, you can't have anything. And it's just not, just like a normal MRI, it's just not true.
Yes.
Sorry, can I quickly ask, with regards to managing this patient's expectations and the symptoms in the meantime, because from the time of we got the diagnosis of confirmed and referring to rheumatology, the waiting time, what can we do best to manage the patient expectations and manage the symptoms? Is there any guideline?
Yeah, I mean, it is clearly you need a quite an in-depth investigation. There is the data from the, I can't remember the name of the blessed study now, Raj and Alex's study with NSAIDs, dynamism study, which looked at how much NSAIDs impact on MRI findings. And if you have an MRI scan whilst you're on NSAIDs, 2/3 of patients rather than 100% of patients are picked up. So 1/3 of them that have AXPAR, it doesn't show. But if you stop the NSAIDs 2 weeks before, it's okay, it shows. It's essentially what it roughly showed. So it's not unreasonable, if you think somebody's inflammatory, treating them with some NSAIDs, probably with a PPI as well, is completely reasonable, and it also helps the rheumatologist. Because they can go, when you started it, what were you like? How quickly did you respond? And it's one of the criteria that we use. So you're making the rheumatologist's job easier. That's okay to do.
I was just going to highlight the dynamism study. Certainly, if people are requesting MRI scans to investigate for AXPAR, just advise the patient to stop their NSAID 2 weeks before the scan.
Thank you very much. Well, some interesting questions. That was really great. Thank you, John.